Entitled Fluid and Critical Care. Our first speaker will be Prof. Jean-Louis Vincent, and I think he has been introduced many times throughout this conference, so he is a well-known international figure. He's a professor of critical care in Belgium, and I'm not going to say any more than this. Welcome, the floor is yours.
Thank you very much indeed, Mr. Chairman. Once again, it's a pleasure to be here. And in this talk, I will propose to you that fluid administration and vasoactive drug administration can be largely automated. This could be done almost continuously and can be personalized. It's very important to consider every single patient as an individual. We cannot target the same values for all patients. Let's start with the blood pressure. What is the optimal blood pressure in my critically ill patient? Let's say a patient with septic shock. When I ask my young residents, sometimes they say, a mean of 65. Yeah. I say, why? Oh, that's in the guidelines. I say, no, that's not true. No. Look at this old French study, a study that I criticized from the beginning. I said, you know, it doesn't make sense to randomize patients with septic shock for one target blood pressure or another target blood pressure. You will never find a difference in mortality. And indeed, there was no difference in mortality. Does it mean that blood pressure doesn't matter? No. It means that some patients need a higher blood pressure than others. And some other patients are better off with a rather low blood pressure. Now, this study actually was interesting because the target was either 80 to 85 mean arterial pressure or 65 to 70. But in this kind of study, we usually go over the target. That's okay, that's human nature. So in reality, it was 85 versus 75. You can see it on the graph, on the figure of the paper. And yet, when you look at the subset of patients with a history of hypertension, you can see that they needed to be in the higher target group. So a mean arterial pressure of 75 is too low for some patients. Oh, okay, so we should go to 75, right? Let's put 75 as our target value. No. Look at this study called 65. It's a double 65. 65 years old or older, 65 mean arterial pressure, or allow it to be lower than 65. No difference in mortality. The same explanation. Some patients may need a higher blood pressure than others. You can see a recent meta-analysis of individual values showing that indeed a mean arterial pressure lower than 65 may be okay in some patients. So, mean arterial pressure higher than 75 is needed in some patients. A mean arterial pressure lower than 65 may be acceptable in some patients. This is becoming confusing, right? Well, to some extent, because if you accept that it should be personalized, then it's no longer confusing. Things actually get together very well. So what about our guidelines? Well, our guidelines are not wrong. They say we recommend an initial mean arterial pressure of 65. But people forget about the word initial. It's 65 for everybody. 65, 65. No! In our previous guidelines, we even added a sentence which is very important, saying if initiated vasopressor dosing should be titrated to an endpoint reflecting perfusion. So it's not always 65. And that's how, following the most recent guidelines, we wrote this paper saying, wait a minute, the guidelines do not insist enough on personalization. And so our European guidelines will come out soon. I cannot give you all the details. It's not published yet. I am in the group with others, and we write, we recommend individualizing the target blood pressure in patients with shock in general, not only in septic shock. And we recommend targeting an initial value of 65 in patients with septic shock. The word initial is there. And we recommend a higher minatory pressure in patients with a history of hypertension. But sometimes this history is not very clear. You don't know when you start to treat a patient whether or not there was a history of hypertension. So we need to put our hands on the patient. We need to examine the patient. We need to consider the history, but also diuresis, also consciousness, skin perfusion. And of course, with vasopressors, we do not want the patient to be vasoconstricted. So we need to have an assessment of flow. The blood must circulate. It's not just blood pressure. We cannot treat shock just with vasopressors. That would be a big mistake. Vasopressors are okay when there is vasoplasia, when flow is high. But if flow is low, giving a vasopressor may be very harmful. And if we think about it, that's the reason why, or the primary reason why, noradrenaline is our favorite first agent. Because noradrenaline has some moderate, but some positive inotropic effects that other agents do not have. Phenylephrine, vasopressin, angiotensin, they do not have any inotropic effect. So it's a bit safer to give a vasopressor having a little bit of an inotropic effect. So that's what I call the noradrenaline challenge, but it is not sufficient just to give noradrenaline and leave the patient there. We need to avoid vasoconstriction. We need to think at fluids. Wet or dry, that's a wrong debate. It needs to be adequate. Some of our colleagues wanted to randomize patients for more or less fluid. That's not the right question. And you can see in a restrictive group, they gave fluids only when the patient was about to die. High lactate, minatory pressure less than 50, mottling, anuria, then you can give them fluid. Once again, no difference in mortality. So they didn't kill patients with that? Well, hopefully the patients had already received quite a bit of fluid. Hopefully they had already received about 3 liters of, it's here, about 3 liters of fluid before they were entered in the trial. So they were already in the stabilization phase, and that's okay then to limit fluid administration. In this other study, some people call it septic shock. It's not true. It's sepsis-induced hypotension. Many of these patients were not in the ICU. There was a difference in the amount of fluids and vasopressors, and those patients who were in the restricted fluid strategy group were more likely to go in the ICU. You see, 67% versus 59%. So there is no advantage whatsoever in fluid restriction. It can just impair healing. It can just hurt the kidneys. But this requires some type of monitoring. It's not a single variable. The central venous pressure, oh no, very bad. Okay, but the arterial pressure doesn't tell you if the patient needs fluid. The heart rate does not. The cardiac output does not. The urine output does not. So you cannot use. And so as I said yesterday, if you need to integrate variables, you need to be very, very intelligent. Our human brains cannot really put together more than 2, 3, 4 variables. That's really a maximum. But already a number of years ago, it was proposed that with advanced statistical methods, we could indeed integrate variables. And this could be done, of course, in the optimization phase. It's already not so easy to use the Frank-Starling relationship at the bedside to say, okay, if cardiac output increases, I'll continue to give fluids. The patient is fluid responsive. Now, at some point, cardiac output may no longer increase very much, and then we need to stop. That's what we call the fluid challenge. Now, very importantly, the time should be limited because we don't want to give too much fluid with our challenges. We don't want to give each time 500 cc's or 1 liter. No, if the patient does not respond, that will result in edema. And we do not want to have interferences of other interventions. We want to keep it short so that we can assess the effect of our fluid bolus, right? And Dr. Cecconi reviewed the literature on this, and it's interesting. It's not rocket science, but it's a small literature review to indicate what we know. Very often, people give relatively large amount of fluids in more than 20 minutes, in half an hour. Oh, give 500 cc's in half an hour. That's not a fluid challenge, my friend. No. That's just fluid administration. So this is really very important, and it shows that we could do it better, and that an AI-based system could do it well for us in 5–10 minutes, as it should be done. Nothing should change during the test. 5–10 minutes, limited amount, maybe 200 cc. The exact amount doesn't matter, and the exact period of time doesn't matter so much. It should be short, the amount of fluids should be limited, but still quite reasonable. So that's how we today recommend something like 200 cc's in 5–10 minutes. I don't give it in cc's per kilogram. I'm sorry, I never tell a nurse give 5 cc's per kilogram. He would look at me and say, what do you mean? We give it with fixed amounts. And we need to measure optimally cardiac output, not just blood pressure, if this is a patient with some degree of dilation. We can use the system we like, but the point is that this can be standardized. So it could be done without an intervention of a doctor or a nurse at the bedside. These are our current recommendations for fluid assessment. We look at cardiac output and some index of cardiac filling. Central venous pressure is fine. And then, indeed, if cardiac output increases with minimal price to pay, with limited increase in CVP, we may continue. If cardiac output does not increase, we stop. These guidelines, as I said, will come out soon, and we recommend to assess fluid responsiveness. We suggest assessing the risk of harm with fluid administration. We recommend measuring central venous pressure whenever possible. And we recommend the use of echocardiogram. I showed you the slide yesterday. I showed you that now we could see the heart beating on the computer screen. with small probes in the esophagus. But we could also have a transthoracic echo in the future with automated analysis. Automated analysis, VTI, can be obtained automatically. This paper just came out to show how we could analyze echography, being the lungs, being the heart, by non-experts using an AI system. Wow, yeah, indeed. This could be done automatically. In the future, we will have very simple
5 minutes.
system to put on the skin to have some assessment of flow. So dealing with multiple variables is indeed obtainable by AI system. And so we recommend against relying solely on a single variable, not just blood pressure for sure. We need to have serial assessment of tissue perfusion. And we know that fluids can have their problems of edema. We know vasopressors can have their problems of vasoconstriction. And we learned already in 2018 that the AI-based system could help us to choose between more fluid or more vasopressors. So the systems are virtually there. Airway management, we could also combine different variables, but I will skip that to say that digital twins could be used. The system could tell us, if you give more fluids, this is what will happen from our database. If you need more, if you give more vasopressors, this is what will happen. Or here, if you intubate the trachea, or if you don't intubate the trachea. So there are many variables to look at, and to integrate this, AI could definitely help us. Even to predict hypotension, we know there are some systems now allowing us to predict hypotension. In the last 2 minutes, I will show you what we have done in the operating room, because actually these concepts could be more easily applicable in anesthesia than in critical care medicine. We have the past history of the patient, we know what we are doing to the patient, and we will follow up the patient later. So I like this sentence: we are convinced the machine can do better than human anesthesiologists. That was written a number of years ago. We already know that in the OR, it's intelligent to try to keep the blood pressure not within a target range, but the target range defined for this patient. If the patient has a history of hypertension, you know it, so you can already keep that range. With Dr. Justin, we first used closed loop system to adapt the noradrenaline dose automatically, no intervention needed. But once again, it's not just blood pressure. We need to maintain flow. Excessive use of vasopressors can harm the patient. So fluid administration, in the OR, we cannot do it in 5–10 minutes. We can do it in 1 minute. That's what some people have called the mini fluid challenge. So this could be done automatically. And indeed, some years ago, a number of anesthesiologists, including Dr. Justin in our group, he's now in California, but when he was in Brussels, we studied the way to do fluid challenges automatically. And other groups have done it as well. So now you have a combination of vasopressors and fluid administration done automatically by an AI-based system. And you can see here that actually the system does better than human anesthesiologists to keep the blood pressure within the range, which is optimal for the patient, and cardiac output within the range that could be optimal for that particular condition. And finally, if the patient does not respond to fluids, any longer or not at all. Then if flow is insufficient, we have no other option, then go for an inotropic agent. The heart rate is okay, the pacemaker will not help. Blood pressure may be borderline, we cannot use a vasodilator. So to increase cardiac output, if it's not fluid, it can only be the inotropic agent, the dobutamine. We could look at SCVO2. If it's low, it's a further argument to give an inotropic agent. And that's again what we wrote in these guidelines that will appear soon. If the patient has a central venous catheter, go ahead and give dobutamine. You could even look at the PCO2 gradients, if you like, in addition to SCVO2 to have an additional fluid. So that's what I call the dobutamine challenge. And I will, we'll stop here. That's my third challenge. That could be done automatically. You can look at an avatar on the screen in the operating room. So that helps you to put the things together. Not just one variable, the combination of variables. So we just wrote this paper about the future in anesthesia, saying that the patient submitted to major surgery has a number of monitoring systems, but the signals are integrated, are interpreted almost continuously by an intelligent system. Robots will perform anesthesia in the near future, and that will come in the intensive care unit as well. Dr. Pinsky, I suppose, presented his new data on automated management of hemorrhagic shock in this case, and that can indeed be applicable in the ICU as well. So, as we said yesterday, this may in part replace the doctor, maybe, but for a better. So the future is personalized hemodynamic management, closed-loop systems, and artificial intelligence. Protocolized care? No. Intelligent care. That's the future. Thank you very much.
Thank you, Professor Vasa, for excellent talk. It's my honor to invite Professor and Chair, Department of Critical Care, Professor Sean Buckshaw. Professor Sean is the Professor and Chair of Department of Critical Care Medicine at University of Alberta, Edmonton in Canada. His expertise in acute kidney injury, renal replacement therapy, frailty and vulnerable patients, and end-of-life care in ICU setting. He's been introduced many times, so I am just putting his brief introduction. Professor Shaw.
Thank you so much for the opportunity to speak this morning. Thank you, advisors, for the privilege of being able to visit Kuwait and participate in. And it's always a pleasure, if not somewhat intimidating, to follow Professor Vincent and his illuminating presentations. I've been tasked with talking a little bit about fluid therapy, type dose, and controversies, if you like. So these are my disclosures. I'm happy to discuss if you have questions. I just wanted to start with some data from the Safe Trips trial that was done in 2017. It's a little bit older now, but a surveillance of fluid use across the world. And you can see here that predominant fluid use is crystalloid, but still about 20% colloid is used for fluid resuscitation. You can see that half and half balanced versus 0.9% saline. And amongst colloids, you can see the majority is actually albumin, but still a significant, not insignificant proportion of hydroxyethyl starch is used. I want to compare this as well to the FINIS trial that was done, a European study, again, looking at total fluid use across most of Europe. And what was really interesting here, again, similar findings, right? 3/4 of all fluid given is crystalloids, most of it half and half balanced versus 0.0% saline. Colloids constituted about 20-25%, most of which was HES, in fact, starches rather than albumin solutions. But one of the things that dovetails nicely with Professor Vincent's presentation is here. What were the indications for giving fluid in this survey of practice? Well, it was hypotension and oliguria, right? And I think the thing that shocked me most when I looked at this again was that 43% of all fluid boluses were given with no variable used to actually determine whether patients were going to have responsiveness, either improvements in cardiac output, improvements in mean arterial pressure, improvements in peripheral perfusion, etc. So that's astonishing. Now, I would like to see a repeat survey done today and whether that's changed over time, but nonetheless, food for thought, something to think about. Let's briefly talk about colloid solutions. These are the colloids that are most commonly sort of available, I suppose, in the market. This is an up-to-date systematic review done by Lewis and colleagues in the Cochrane Library. And I really just want to highlight one point. If you look at all these different solutions, all these different sort of colloid solutions, there's really no signal across any of them for a benefit in terms of any patient outcome, right? Across the board, there's really no clear benefits of using any specific colloid solution for patient-centered endpoints. If anything, there is some signals for harm. And if you look at the clinical practice guidelines, 2021, surviving sepsis, you can see here that there is a weak recommendation for using albumin in patients who received large volumes of crystalloids. Now, the fourth talk this morning in this session will be on albumin by Dr. Nazir, so I'm not going to go into it in too much detail, but I wanted to highlight a couple of trials that have been published very recently. So this is the ABC sepsis trial, which was designed as a pilot trial looking at the use of albumin versus balanced crystalloid for fluid resuscitation in critically ill patients with septic shock in the UK. And what's interesting to see here is that there is an absolute increase in 30-day all-cause mortality associated with the use of albumin, right? Maybe not statistically significant, but certainly some large effect between the two, suggesting that certainly albumin is not proving to be beneficial in this population and may in fact have a signal of harm. Moreover, if you look at the utilization of vasoactives, or if you look at complications like pulmonary edema, these were experienced numerically more commonly in patients who were allocated to the albumin solution. So this was a pilot study. But if this is a pilot feasibility study looking to see whether there's signals to suggest that albumin might have some benefit in this population and or is associated with less complications, I'm not sure there's enough evidence here to move forward with a definitive large multi-center trial. So I don't know what's happening with the AB sepsis trial, but certainly some concerns about whether there may be some toxicity. This is a retrospective cohort study, large database used in the US, looking at albumin exposure to patients who are undergoing cardiac surgery. And what's interesting is that there's suggestions here that there is an improvement in mortality associated with the use of albumin in cardiac surgery, and that the use of albumin was associated with a reduction in 30-day all-cause admissions or readmissions to hospital. But I just want to point out here that if you compare crystalloid with albumin, there was a numerically lower rate of acute kidney injury associated with crystalloid versus albumin, i.e. albumin had a higher rate of acute kidney injury. Not statistically significant, of course, but clearly in terms of a renal outcome, there is no suggestion that there's a benefit to albumin use in this context. And I think that's something important to recognize because very recently, this trial has been presented, not published in final form yet, but the Albix trial presented at the Critical Care Reviews Down Under in December. And basically, this was a multi-center randomized controlled trial looking at albumin utilization amongst patients undergoing cardiac surgery. These patients were 611 patients. These were older patients with higher risk features during cardiac surgery. And what's interesting, the primary endpoint was AKI events defined by KDIGO criteria, 49% in albumin versus 43% in control. So here, albumin is showing some incremental hazard associated with AKI events. And I think that's really important to recognize that maybe there's some evidence to suggest that albumin is not necessarily as banal as we think it is and may be associated with some hazards. I'm going to briefly touch on hydroxyethyl starch. This is the VICEP trial, patients with severe sepsis getting hydroxyethyl starch, 200 to 0.5. And basically a dose gradient increased risk for utilization of renal replacement therapy amongst those exposed to starch and septic shock. This was followed up by the 6S trial that basically showed, using 130.42 hydroxyethyl starch in a balanced solution versus balanced crystalloid, showing there was an increased risk of composite death and or renal replacement therapy utilization and renal replacement therapy utilization. So again, a clear signal for hazard in these patients. And what's important to emphasize, and I always like looking at the survival curves in the success trial, but what you see here is that the separation in survival doesn't occur until about 2 weeks after the exposure. And it may be that either many of these patients are dead or many of these patients have left the ICU, and that hazard exists long after when patients initially receive that therapy. Moreover, now you have the CHEST trial, huge sort of huge sort of trial done in Australia and New Zealand intensive care units, looking at all comers to the ICU using 6% HES as resuscitative fluid compared with 0.0 saline. And again, same hazards, increased evidence of acute kidney injury, increased utilization of renal replacement therapy, increased adverse events. So I think these trials in the context of critical care have largely led to these recommendations by the FDA and the EMA for the restricted use or the removal of the use of HES in these populations. I'm not sure what the practice is here in Kuwait or in other Arab countries, but certainly there is no strong rationale for use of these drugs, if you like, as fluid resuscitation strategies in critical illness. Plus, they're 40 times more expensive. Okay, so obviously that aligns with clinical practice guidelines. Let's go into crystalloids for a brief moment. So crystalloids, I love the term normal saline. I don't use it because it's not normal. And in fact, what's really interesting to me is this, just a little medical history for you. In 1888, this is the first time the term normal saline is used in the medical literature. And I want you to be clear about what was in this formulation at the time. 3 drachms of chloride of sodium, 18 grams of chloride of potash, 9 grams of phosphate of soda, 60 grams of bicarbonate of soda. This was a balanced solution, not normal saline. Normal saline, as originally defined, was more aligned with today's plasmolite than it was with 0.0% saline. But clearly, does the type of crystalloid matter? And I think when we think about 0.0% saline, saline contains sodium and chloride in equal quantities. That is not like plasma. Adding saline to plasma increases the chloride content relative to sodium content, and this has implications for reduction in plasma strong ion difference and will contribute to an iatrogenic hyperkalemic metabolic acidosis. And we know this from experimental studies. This is an older study now looking at changes in renal blood flow following resuscitation with 0.9% saline versus a balanced crystalloid solution. And you can see the clear decremental effect that 0.9% saline had in renal perfusion in these animals. Day3 Lodo did a really interesting study in the UK not long ago, or like actually about a decade ago now, looking at basically a crossover study of healthy volunteers, giving them 2 liters of saline quickly, probably as a fluid challenge, and then giving them 2 liters of balanced crystalloid solution, and then measuring a series of biochemical parameters, including MRIs of perfusion of their kidneys, to see what the effect of these 2 solutions was on these parameters. And what was really interesting is you saw big differences in serum chloride. 0.9% saline increased the chloride in the blood. It decreased the strong ion difference, and that was consistent with an iatrogenic metabolic acidosis, but it also had decrements really quickly in renal blood flow and renal cortical perfusion. So there's no doubt that 0.9% saline in sufficient doses can have adverse or meaningful effects on renal perfusion and rates of acute kidney injury. This is a study done a long ago, a randomized controlled trial, again, looking at perioperative fluid loading amongst patients undergoing major abdominal surgery. And what you see here is 0.9% saline versus plasmolite. Patients were giving 15 mils per kilo during their OR. And we look at the biochemical parameters 24 hours later. Clearly, there's a difference with 0.9% saline. More change in chloride, more change in bicarb, more change in base excess. If you got a patient in the ICU after surgery with that kind of biochemical profile, I think you'd be worried that something catastrophic was happening in their abdomen. But this metabolic acidosis is completely iatrogenic. Let's talk briefly about some of the huge trials that have been published in the last few years that have really started to change the landscape. So this is the SMART trial led by Matt Semler and colleagues in Vanderbilt University. Huge cluster crossover trial in their institution looking at crystalloids, balanced crystalloids versus saline in an open label approach in like 15,000 patients. Really, really impressive effort. What they showed was that they could get separation in terms of during the blocks of cluster randomization, patients in the balanced group basically got balanced solutions. Patients in the saline sort of time group got saline. And they showed biochemical differences as well, right? So differences in chloride, differences in bicarbs, suggesting that there was physical, chemical serum effects of these solutions. But they really showed what was really important, what they really showed was there was a difference in the major adverse kidney events at 30 days between the balanced and the crystalloid solutions. Small, but significant, right? So there was a lower event rate for MAKE 30 in the balanced solutions versus salines. And this was consistent across mortality, across utilization of renal replacement therapy, and across the renal endpoint specific, which was a doubling of serum creatinine. And here you can see the sort of components of the MAKE 30. In adjusted analysis, when they tried to stress their data, looking at how robust it was, they found there was differences also in hospital mortality and a composite of hospital mortality and renal replacement therapy reduction for those getting the balanced compared with the saline solutions. Now, they did a subgroup effect, so there was some suggestion that there may be more of a heterogeneity in treatment effect amongst those receiving balanced versus saline solutions in sepsis. And here's the sepsis subgroup that was published a short time thereafter the trial. And again, you can see mortality, MAKE 30, vasopressor, and renal replacement therapy free days, all seemingly favoring a balanced versus 0.9% saline solution. So we come on to the PLUS trial, which was an Australia, New Zealand Intensive Care Society, huge trial that was actually terminated prematurely because the BASICS trial from New Zealand or from Brazil had been published in the meantime. But really, again, looking at saline versus plasmolite, 90-day all-cause mortality, also looking for signals of harm related to saline in terms of AKI and renal replacement therapy use. Again, they saw differences in biochemical profiles in the plasma. They basically showed that serum creatinines were stable through the first 7 days. This is a huge pragmatic trial, all comers to the ICU, really not enriched with populations of patients who we think might more or less benefit from one solution versus the other. But they really showed no difference in mortality across overall or across any subgroups per se. Which brings me to the BASICS trial, which is the largest comparison of saline versus balanced crystalloid solution performed yet in critical care. This looked at all comers to ICUs in Brazil. Patients had to be critically ill, in need of fluid, and have a risk factor for acute kidney injury. The primary endpoint was 90-day all-cause mortality. They also looked at hazards like renal replacement therapy use and other sort of measures. What's interesting here is they showed no differences in serum creatinine over time. They clearly showed there was differences in chloride, suggesting that there was, again, some effect of saline relative to plasmolite. They looked at the impact of having a high serum chloride following resuscitation, and there was no evidence of heterogeneity and treatment effect here as well. And then when you look at the prime secondary endpoints, so all the primary endpoint and secondary endpoints were largely negative for the most part, but when they really teased in to look for acute kidney injury differences, they didn't find any. And they really did their best to stress the data here to try to see if there was clear evidence that one solution favored the other. Having talked to my colleague, Fernando Zampieri, who is now with us in Edmonton, Canada, this led to a whole-scale change in policy across Brazil to adopt 0.9% saline to save a few pennies per bag, to say the least. That being said, all patients within this cohort were not the same. So here is the traumatic brain injury group, right? So if patients with traumatic brain injury were receiving a balanced crystalloid solution, they actually had an increased hazards for mortality, and there was heterogeneity and treatment effect here. So we'll come back to that because I think that's an important subgroup of patients that may not benefit. Now, one thing they've done in BASICS was they looked at the baseline fluid received. So Dr. Vincent very nicely showed that in the classic trial and in the Clover's trial, patients come in and they receive a lot of fluid before they're enrolled into the trials. So what they looked at here was the baseline fluid received by patients enrolled in BASICS, whether they received only saline or whether they received only balanced crystalloid solutions. And in the secondary analysis, what they looked at was those patients who only received balanced crystalloid solutions as their pre-trial fluid, basically randomization to balanced crystalloid solutions was associated with a significant reduction and a higher probability of benefit with balanced solutions relative to saline across a series of subgroups in this trial. So again, if we're talking about individualization or personalization or using sort of advanced statistical modeling to try to understand who to get what fluid at what time, here's some evidence to suggest that balanced crystalloid solutions may actually be, in these subgroups, more beneficial than saline. And so obviously, Fernando Zampieri and colleagues led an individual patient data meta-analysis of all these big trials. And basically what they found was that on whole, balanced crystalloid solutions are probably associated with a reduction in odds for negative outcomes in terms of mortality for patients. And the probability, using a Bayesian hierarchical approach, the probability of balanced crystalloids having a benefit relative to saline was about 90% across this analysis. Importantly, two subgroups that came out that were important. Again, traumatic brain injury. If you have a patient with traumatic brain injury, and I know this group is currently looking at non-traumatic brain injury, neurologic-related events in patients. So if they have an acute brain injury or another neurologic event, whether saline versus balance is important. But in TBI, basically saline is probably your fluid of choice, right? Balanced crystalloid solutions are associated with some heterogeneity in treatment effect and worse outcome. And then pre-study fluid, if you receive saline, there seemed to be a greater hazard for, if you received no saline and only balanced solutions, there was a greater effect to favor balanced crystalloid solutions. So here you can see the clinical practice guidelines in terms of 2021 for the use of balanced crystalloid solutions instead of normal saline for resuscitation. So the evidence caught up with the guidelines to some extent. What about fluid accumulation and fluid overload? Again, I think Professor Vincent sort of primed this very nicely about the individualization of fluid. Most of what I'm going to talk about here is in the optimization or stabilization phases, the late fluid management that occurs in our critically ill patients. So here's some secondary analysis from the VAST trial. And basically what this will tell you is that for the most part, if you have a high positive fluid balance after initial resuscitation and you have a high CVP, so you have systemic venous hypertension, and if you accumulated a ton of fluid, you are more likely to die. Similarly as well, in patients with acute kidney injury going on to receive renal replacement therapy, if one of the drivers of your initiation of renal replacement therapy is complications related to fluid, and you have fluid overload at the time of initiation of renal replacement therapy, you have a twofold higher risk of death. We know about the FACT trial suggesting that conservative fluid management after initial resuscitation is associated with improvements in terms of ventilator-free days, but also less utilization of renal replacement therapy. And then I just wanted to touch on the Clovers trial, which was more of a pre-ICU, right? Early sepsis-induced hypotension, not septic shock like Dr. Vincent had highlighted, suggesting that perhaps, after initial resuscitation, a conservative approach to fluid management may be acceptable. It's going to be a Goldilocks phenomenon where we're probably using a little bit of both on either circumstance. The trade-off here is, though, if you're going to have a very conservative fluid management approach, you're going to probably need a little bit more vasopressors to maintain perfusion. And the issue there is the only place you can be maintained and observed and supported for that is in the ICU. So there's a trade-off here that if you adopt a very conservative approach, which doesn't seem to have any increase in mortality, these patients were more likely to go to the ICU because there's nowhere else for them to be disposed in the hospital. The classic trial also probably gives us some information to suggest that we can get away with a little bit less fluid post-resuscitation, and it doesn't have any adverse effects per se on this population. However, I think there are populations of patients who, when we restrict fluids, and I don't like to use the word restriction, but when we use a very conservative approach to fluids, harm may occur. Perioperative fluid management, these patients with conservative fluid approaches had higher rates of AKI and utilization of renal replacement therapy, which is a signal for harm, right? So patients undergoing elective surgeries. And then in ARDS, this is a secondary analysis of the FACT trial, but these are provocative data too. It's older, but suggesting that conservative fluid management strategies could be in a select population of patients associated with adverse effects in terms of cognitive outcomes long-term. Okay, final thoughts. So fluids are drugs, and they should be prescribed accordingly. Colloids in the ICU generally have unproven value in terms of outcome benefit for patients, certainly relative to the cost. The cost is something like 20 to 30 times more for albumin and starch solutions relative to crystalloids, with few exceptions. 0.9% saline can alter the biochemistry of our blood, as we know, and there's generally few indications for 0.9% saline, but TBI, possibly other neurologic diagnosis, we'll see new data coming on that soon, and others. Meta-analysis basically show there's a high probability that, for the most part, balanced solutions should be our default. And then secondary analysis show that Heterogeneity and treatment effect by baseline fluid exposure and case mix. We're sorting that out, but we're probably going to learn a lot in the next few years as new data emerges. Thank you so much.
Thank you, Professor Sean. It's my privilege to invite Professor Oliver Jones. He is Head General Manager of Anesthesiology and Critical Care Department at University Hospital of Bordeaux, France. He works in the field of acute kidney injury, renal replacement therapy, and multi-organ support therapy.
And you can use a
for
digital
about 20
pointer.
years.
This one,
He is
no,
the
press
Vice
and hold
President
move.
of
It will
French
show,
Society
it will
of
show on the screen.
Anesthesiology and Critical Care.
If you want, otherwise you can
Professor Oliver.
Thank you, dear Chairman. Could you switch? Good morning, everybody. Just we are waiting for the slides. I will talk about the. Thank you. I will talk about the sodium bicarbonate. Many people just say bicarb, but not. It's sodium bicarbonate, and this point is really important. The question is bridging the gap. May the sodium bicarbonate be the missing piece. We will see this. Some links of interest, but not with this presentation. Why to use sodium bicarbonate? Sodium bicarbonate is not a fluid for filling patients. Never. But perhaps we can use sodium bicarbonate for hyperkalemia if you face some metabolic acidosis. And you can also use sodium bicarbonate for patients that lose sodium. In the specific situation, you have some situation like biliary fistulas, diarrhea, or ileostomy that you will lose a large amount of sodium. In that case, you can use sodium bicarbonate because you will bring sodium without chloride. If you have some subpyloric losses, you will face hyponatremia, acidosis, hyperkalemia, and some extracellular dehydration. In that case, you can use some balanced crystalloid where you bring some sodium with a low level of chloride, but the best is probably sodium bicarbonate because you bring sodium without chloride. And at the end, do we have to use sodium bicarbonate to correct metabolic acidosis? Is the question. But why? And which pH target? A normal pH can be the result of multiple opposing disorders. You have a normal pH, but you have a complete discrepancies in acid-base balance. But you have a normal pH. We will see this after. Normalizing the pH. Why? This is just symptomatic. It's not an etiological treatment. You just want to see a good number in the pH line, but what a big deal. What evidence is there of the harmful effects of acidosis? In fact, acidosis is just an adaptation to an outside aggression. We will see this. It's a beneficial adaptation at the beginning. And what are the risk benefits of alkalinization with sodium bicarbonate? In fact, when you have a metabolic acidosis, you have only 4 mechanisms. In fact, just 3, and the 4th is the association of different mechanisms. You may have hyperlactatemia or hyperketonemia or hyper some undosed anions. You may face also hyperchloremia or hyponatremia. This is a discrepancies between the 2 big ions for the pH is sodium and chloride. And the third possibility is a failure to eliminate the NH4+. Only 3 mechanisms to explain metabolic acidosis. Go back to the physiology. You can use this approach. It's very simple. You have HCO3 and the H plus, and at the end you have the CO2 and water. But you cannot understand exactly how it works. And we have the anion gap that is able to differentiate the metabolic acidosis due to an organic ion accumulation, is the undosed anion, or the discrepancy between the sodium and the chloride in favor of chloride. An accumulation of chloride will bring a metabolic acidosis. And the best is probably to go to Stewart approach. With Stewart, at the end, bicarbonate is not the cause of disorders. It's just the reflect of the change in metabolic equilibrium. The pH, in fact, is dependent of 3 different factors: the strong ion difference, the weak acid concentration, and the PCO2. It's a bit complex with a lot of equation. As I said yesterday, this book with 300 pages of equation is really complex. We are few people in the world to read this book, and some are becoming mad. But we can try to see Stewart more simple. The Stewart theory, very simply just in this picture. It's simple. You have cations on the left, and cations are prone to go to alkalosis. It's positive, and anions are negative and are prone to go to acidosis, like hyperchloremia, hyperlactatemia, and so on. Hey, you will see the bicarbonate is on the right. Yeah, but the bicarbonate is the lone ion that is directly linked to the outside with the ventilation. And the bicarbonate regulates the electroneutrality. It's mandatory to have the equality between plus, the positive and the negative charge. If not, you are a battery, and we are not battery. And the bicarbonate is not the cause, it's just the reflect of the change in metabolic equilibrium. When you give sodium bicarbonate, you give sodium and bicarbonate. You will metabolize bicarbonate in sparkling water, CO2 and water. And at the end, only sodium will remain in the patient. It's the same with lactate, acetate, or citrate. Sodium, if you are able to metabolize the anions, at the end, only sodium remains in the patient, and you can alkalinize the patient due to the increase of sodium level. When you face metabolic alkalosis, you have 2 different possibilities. An accumulation of undosed anion, like lactate, or accumulation of chloride, an increase of chloride concentration. But in ICU, most of the time, our patients have a low level of albumin. And sometimes you have a normal pH with a total disequilibrium in metabolic, in your metabolic equilibrium. As you can see there, the pH is normal, but you have hypoalbuminemia, hyperlactatemia, and your pH is normal. And you want to give sodium bicarbonate there? No. The question is, does a low pH kill your patients? No. You can see there, it's not 7.25. It's a pH below 7. And less than 50% of patients will die with a pH below 7. Okay, we have some deleterious effects of acidosis on the cardiovascular system. We have many studies, but most of them are animal studies. we are on isolated heart or wild animal. And sometimes, with animal studies, we have some reversal effects with the sodium bicarbonate. And also you have a risk of an increase in heart rhythms disorders. And most of my residents say, oh, but you have a catecholamine resistance with acidosis. Do you have a study? No. No. No good study proves that you have a catecholamine resistance with acidosis. It's a fake. And in most of the studies like this one, you don't have difference in catecholamine effect with acidosis. And you have beneficial effect of acidosis. As I said, acidosis is an adaptation to outside aggression, because you will decrease the depletion of energy reserves, and you will right the deviation of the hemoglobin dissociation curve. You are able to give more oxygen to the peripheral tissue. It's a good thing for the organs. On the other hand, you have some deleterious effects of sodium bicarbonate. You will increase the CO2 production, and you have to remove it. And you will face some paradoxical intracellular acidosis with this. You have an increases the affinity of hemoglobin for oxygen, and you are less able to bring oxygen to the peripheral tissue. You have some rebound of alkalosis, and you may increase lactatemia. And also some hypocalcemia, hypokalemia, and hypernatremia. Do we have studies that prove sodium bicarbonate is interesting to correct metabolic acidosis? Not so much. And only in very particular patients. In their study, the lone groups that benefited of sodium bicarbonate infusion is patients with acute kidney injury. Why? Because acute kidney injury will bring a discrepancy between sodium and chloride in favor of chloride. An increase in chloride and also an increase in phosphate. And you have a metabolic acidosis due to this. In this case, you will correct a bit this discrepancy in giving sodium without chloride and decrease the difference between the chloride sodium in favor of chloride. But if you have patients with cardiac arrest, no difference in terms of all the parameters, even if for neurological benefits. Why? Because in those patients, it's not a discrepancy in sodium and chloride, it's lactate. And give sodium bicarbonate to fight metabolic acidosis due to hyperlactatemia is a nonsense in physiology. The big study, VICAR-ICU, the largest randomized control trial on sodium bicarbonate infusion from metabolic acidosis. And you can see 7.2 with a normal PCO2, and they gave sodium bicarbonate, and small beneficial effect for a composite outcome for the patient, but for the patient with acute kidney injury. The same, for all the patients, you have no real benefits, but for specific population of acute kidney injury, perhaps you have a beneficial effect due to a metabolic acidosis due to a discrepancy on sodium and chloride, not due to the accumulation of undosed anions. We will wait for the next study, the BICA ICU2, that will focus more on patients with metabolic acidosis and acute kidney injury to see if really we have to give sodium bicarbonate in this specific population. But for the moment, sodium bicarbonate may be used in case of hyperkalemia or sodium loss. Okay, this is physiologic. You have hyperkalemia with metabolic acidosis, you give sodium bicarbonate, and the potassium go back to the cellular. Or you lose some sodium, you give sodium without chloride. This is physiologic. And metabolic acidosis has some deleterious effects, but also a lot of benefits. And at the end, probably, sodium bicarbonate is reserved for metabolic acidosis with acute kidney injury due to ionic disorders in the sodium chloride equilibrium. This is also quite physiologic. But we have to wait by ICU2 to see if it's really true. But probably sodium bicarbonate is not the missing piece. We don't have to bridge the gap for all the other patients. We cannot correct in accumulation of undosed anions with sodium bicarbonate. You can just change perhaps the pH value, and you will be happy with this, but that will not save the patient. If you use sodium bicarbonate only for specific patients, the best is to use a slow and a regular administration, less than 2 milliequivalent per kilo per hour, to avoid a massive CO2 production and an intracellular acidosis, and also perhaps LCR, the acidosis. The best is probably to use an hypoosmolar solution. 1.4. Don't use the 4.2 or more, the 8.4. You can kill the patient with 8.4% of sodium bicarbonate. It's really hyperosmotic, and you will face an enormous cellular acidosis with this. CO2 removal capacity is important. You have to keep this in mind. You have to prevent hypokalemia and ionized hypocalcemia, and you have to limit the amount of sodium bicarbonate that you gave. Thank you for your attention.
Thank you very much, Dr. Now it's my privilege to Dr. Lama for her next talk. Dr. Lama is a board-certified pharmacotherapy specialist and fellow of critical care medicine. She is the clinical affairs manager of the residency program director and critical care clinical pharmacy at King Hussein Center in Jordan. Dr. Lama, she has been introduced many times. I will not go through everything.
Okay, well, thank you very much, and good morning, everyone. It's a morning of controversies, I guess. The most common treatments that we use in our ICU, whether it's fluids or it's albumin, and we've used for so long, but we continue to try to learn what's the best way and the best approach and best patient population to use for. So my topic is also another controversial topic in terms of the use of albumin and who's the most appropriate patient population that we should be using albumin for, when, what, how long, and those kind of questions that come up. So I'm going to touch very briefly just kind of on the physiological functions of albumin, just, very briefly to kind of put things in perspective in terms of why we get excited about using albumin. I'll talk about some of the recent guidelines that came out that provide some guidance in terms of using albumin in the critically ill patients, but again, they still add some controversy related to that. And I'll go through some of the evidence that supported the recommendations that were included in those guidelines. Now, when it comes to the albumin, you know, we're all very familiar with albumin, the physiologic functions of albumin. It's one of the most common proteins that are in the circulation. About 50 or 60% of the plasma proteins is actually albumin. And its major role is in terms of the oncotic pressure. 75% of the blood pressure is maintained by albumin. But it also has other non-oncotic functions. So these are just a few of them in terms of binding and transporting endogenous and exogenous compounds or drugs. It has antioxidant properties, immune modulation, anti-inflammatory, and a lot of other functions that albumin is known for. And hypoalbuminemia is very common, whether it's in our critically ill patients or in the non-ICU patients. And it's been identified as a predictor for poor outcomes. And so this is where the practice of giving albumin came in place, that albumin has so many important functions. Hypoalbuminemia is common. It's associated with poor outcomes. Then the common reaction is, let's give albumin to improve patient outcomes. But it's kind of not as straightforward as I presented it, because there's not a lot of scientific evidence to support using it. And that's where a lot of the controversy comes into place. This is a recent study that came out, which is very similar, I would say, to a lot of what we see in our practices. It looked at the albumin utilization over 9 years. This was a single center study from the University Hospital of Basel, but they included a fairly large number of patients, over 20,000 patients that were admitted to the ICU. And about 20% of those patients had received albumin at least once during their ICU stay. The interesting part was that over those 9 years, the albumin use had increased. And the number of ICU cases that received albumin went up from 5% in 2013 up to over 30% in 2021. The other interesting part is, if you look at this figure, you can see that the amount of albumin that patients were receiving had actually also increased over those 9 years, and the amount of crystalloid that was being received decreased. So there's certainly an increase in terms of the number of patients that are receiving albumin, and also an increase in terms of the amount of albumin that we're giving to those patients. And it's something that we all encounter within our ICUs and within our settings. And that's the reason why we see a lot of these studies that come out looking at the appropriate utilization of albumin. Is there something that we can do in terms of putting protocols or policies or some kind of internal guidance to control the use of albumin? Part of it is the cost. Part of it is that there's concern about mortality, even though there are more signals, but there is that concern. So there's a lot of factors that generate a lot of these studies. This is one of the recent studies that we did, kind of similar to what was published previously, looking at the utilization of albumin within our institution. If you look at the table, we looked at both inpatient and outpatient use of albumin within the oncology patients that we have. It was pretty much, fairly, utilized within all of the services, again, with an inpatient or outpatient. If you look at the last column, which was looking at the inappropriate use, there was also a significant number of albumin that was not considered as appropriately used based on the guidance that was available at that time. But again, it reflects the common use of albumin within all of our institutions, and also the inappropriate use that is potentially seen. These are international guidelines that came out recently, several months ago, and they provide some guidance in terms of the use of albumin in patients. They're the International Collaboration of Transfusion Medicine, and it included, just kind of like any other guidelines, clinicians, researchers, methodologists, and they also had a patient that was involved with the guidelines. And the goal was pretty much to develop some guidance in terms of the appropriate use of albumin. The interesting part was that there were 14 recommendations that were made within those guidelines. only 2 suggested conditional use. The rest suggested not to use albumin. But the other interesting part with those guidelines is if you look at the evidence that supported the use of those, supported those recommendations. So 2 out of those recommendations had moderate certainty of evidence. The remaining recommendations were based on evidence that was considered as with low certainty or very low certainty. So again, even with those guidelines or recommendations that come out, there's still a lot of uncertainty in terms of the evidence that supports them. So we always run into this gray area of, well, this is what the evidence says, this is what my patient has, and this is what I think would work best for my patients. So if we look at those recommendations, as with any guidelines, they usually have either recommend or suggest. Recommend suggests a stronger level of recommendation or a stronger level of evidence. The majority of what was included in those guidelines was also suggest. So that, again, reflects the level of evidence that was used, or the level of evidence that's available for the use of albumin within our patients. I'm not going to go into a lot of details with all of those recommendations. I'm going to focus on 4 main domains because those are the ones that we frequently encounter within our ICU. So there is the first part, which is within our critically ill patients as first-line volume replacement. We also see it being used for the removal of extravascular fluid, generally with diuretics, that a lot of times people tend to combine it with the use of diuretics. Patients undergoing renal replacement therapy, and also patients with cirrhosis. So I'll start with the first one, which is the volume replacement. And with that one, and I think a lot of us are kind of more aligned with that recommendation, where we don't generally use albumin as first-line volume replacement in our patients. So the recommendation was that in critically ill patients, excluding patients with thermal injuries and ARDS, IV albumin is not suggested for first-line volume replacement or to increase the albumin levels. So, for both of those indications, it's not recommended. Now, what about those patients that they excluded, the thermal injuries and the ARDS? They had pretty much the same recommendation, is that albumin is not suggested for those group of patients. It's just that the level of evidence was even weaker for those patients. So that's why they got separated into into a separate recommendation. But again, in both cases, they were not recommended. And it's primarily because most of the studies that have come out showing or evaluating the use of albumin did not show any clinically important benefit with using albumin versus using the crystalloids. So that's primarily the main reason behind that. We also have within the sepsis specifically, there is a specific recommendation regarding the use of albumin, and it's aligned with those recommendations that came out recently, saying that you would not consider it as first line, but in patients that are receiving large doses or large volumes of crystalloids, that it may be considered in those cases. And it's still considered as a weak recommendation, primarily because of the evidence that we talked about. These are the 2 main studies, or probably 2 of the major studies that we're all familiar with. There's the SAFE study and the Albius studies, both of which looked at albumin versus the use of saline for fluid replacement. The first one was a prospective multi-center study. Close to 7,000 patients were randomized to receive albumin or saline. There was no difference in the primary outcome and no difference even within the subgroups that they looked at. The second study was very similar. They had close to 2,000 patients randomized to albumin, 20% with this study versus 44% that was used in the previous study. But they compared that with crystalloid, and again, there was no difference in the primary outcome. There was a study that we were waiting on, which was the ARISE study. That was a study that was trying to answer the same question of whether its albumin replacement would be better than crystalloid. But that study was terminated early, so that we don't have the final results for that one. So we still are going with the same recommendation that albumin is not what we would use in patients as a first-line fluid resuscitation. Now, what about the use of albumin along with diuretics? And that frequently comes up. You try to clear some of the fluids, you want to increase the urine output for the patient, let's give diuretics and let's combine that with albumin. So that's one of the common thing that comes up. And within that those guidelines or those recommendations is that it's not suggested to combine diuretics with albumin, that you would just give diuretics by itself without the need to combine it with albumin. This is a meta-analysis that came out several years ago, but it was looking at the use of furosemide combined with albumin and whether that would actually improve patient outcomes. If you look at the first, see that most of the studies were conducted at least 1 or 2 decades ago. So that's one thing to keep in mind as we're looking at the data. And again, that's one of the reasons why we're seeing relatively weak recommendations that are coming out. But even when you look at the third column there that's highlighted in red, you can also see that the number of patients is fairly small within those studies. But the interesting part in terms of the general findings from that study was that there was a statistically significant increase in the amount of urine volume and sodium that was excreted within the first 8 hours in that group that had the co-administration of furosemide and albumin. But when you look at the 24 hours, there was no statistically significant difference. And I think this is the tricky part when it comes to looking at furosemide and urine output and patient outcomes. Do you want to look at just, do you want to feel happy that there's more urine coming out within that 8-hour time frame, or are we looking more at long-term outcomes within 24 hours or more meaningful patient outcomes out of that? This is another meta-analysis that came out more recently. But again, if you look at the studies, still, we're not looking at very recent studies or large sample sizes. So that's still a limiting factor in terms of our understanding. But it also showed that co-administration of furosemide did not have a statistically significant effect in terms of the increase in the diuresis or natriuresis. They suggested that there may be some benefit within a subset of patients, but the data was very heterogeneous and the sample sizes were very small, so it's hard to really make a clear conclusion in terms of what the benefit would be. Now, what about the kidney replacement therapy? So this is in cases where it's for intradialytic hypotension or to try and improve the ultrafiltration in patients, and the recommendation is not to use it for that indication. So they recommended, or the recommendation was not suggested for prevention of the treatment of intradialytic hypotension or improving ultrafiltration. The data has been kind of conflicting with that part. So this is a study, it was a randomized crossover study, 70 plus patients. There was no difference in the primary outcome between patients that received albumin versus patients that received normal saline. On the other hand, this is a study where they actually found benefit in fewer episodes of hypotension and improved fluid removal with the use of albumin compared to the use of normal saline. So the data has been kind of conflicting in terms of whether you would actually see a true benefit when you kind of apply that to a larger patient population. But maybe this is a study that can provide some insight in terms of the value of albumin within that setting. This is a study where they looked at the implementation of an algorithm utilizing saline versus albumin for the treatment of hypertension associated with renal replacement therapy. And what they did is they changed from their initial approach of where they would give albumin to all of the patients to a different approach where it was more starting with saline, and then if the patients developed hypertension, were still symptomatic, then they would start adding albumin. So it was more of considering it in patients that demonstrate the need for additional treatment. And if you look at the results here, you can see in the pre-intervention where it was giving albumin to everyone versus going through that layered approach, there was certainly a decrease in the albumin that's being used. So that's to show that there are some patients that do well without the need to start with albumin. And then if you look at the other outcomes in terms of hypertensive reversal, time to restore the blood pressure, and the need to terminate or the early termination of dialysis, there was no significant difference between the groups. So maybe there's some value, it's just that it doesn't need to be given routinely for all patients. And again, we have to keep in mind that the evidence is not as strong, but that's at least based on some of these findings. Now I'll move into cirrhosis. I'll move into cirrhosis, and this will be kind of the last indication we'll talk about, but this is where there was some recommendation in terms of giving albumin for those patients, and these are the two domains where they suggested using it. So the first one was for the large volume paracentesis. Paracentesis, as we all know, is associated with post-paracentesis circulatory dysfunction, and it tends to be more frequent in patients that have large volume paracentesis. So we don't see it too much when it's a smaller volume. And this is where the recommendation is that in patients with cirrhosis and ascites that are undergoing large volume paracentesis, which they defined as greater than 5 liters, that in those patients, IV albumin is suggested to prevent paracentesis-induced circulatory dysfunction. There are also other guidelines that came out earlier, which are kind of aligned with that recommendation. So these guidelines came out several years ago from the European Association for the Study of the Liver, and they had similar recommendation of giving albumin in patients who undergo large volume paracentesis. And this is also from the American Association for the Study of Liver Diseases, which also recommended the use of albumin in patients undergoing large volume paracentesis, again defined as greater than 5 liters. The other indication is for spontaneous bacterial peritonitis, and that's also where the recommendations were suggesting to use albumin in those cases. In patients with cirrhosis and spontaneous bacterial peritonitis, IV albumin is suggested to reduce mortality. This is a meta-analysis that was conducted looking at several studies that evaluated the use of albumin in patients with spontaneous bacterial peritonitis. If you look at the first part, looking at the renal impairment, it was certainly in favor of the use of albumin. So improvement with or reduction in renal impairment in patients that received albumin. And also in terms of the mortality, it was in favor of using albumin in patients with spontaneous bacterial peritonitis. There are a lot of other conditions in patients with cirrhosis, and for those other conditions, albumin was not recommended, so they've listed cirrhosis and extraperitoneal infections where albumin is not suggested in those cases. They've also mentioned decompensated cirrhosis with hypoalbuminemia, that albumin is not routinely recommended for those patients, and also mentioned cirrhosis and uncomplicated ascites, that albumin would not be recommended in those cases. So to kind of summarize the controversial part of albumin and the guidelines, albumin certainly has a lot of oncotic and non-oncotic functions, and I think that's the reason we get into this dilemma. It's commonly used, but the main issue with albumin is that we have very weak evidence to support its use. Now, according to the most recent guidelines and some of the previous guidelines that were published, it seems that the two main indications that do have that recommendation of using is cirrhosis undergoing large volume paracentesis and cirrhosis with spontaneous bacterial peritonitis. It's not suggested as first line for volume expansion in combination with diuretics, and also not recommended in patients undergoing renal replacement and having hypertension. So with that, I get to the end of my talk. Thank you very much for being here.
Thank you very much, Dr. Lama. What a great session we had this morning from different topics. And I would like to invite our speakers to the podium for a question and answer session. If we have any questions from the audience, Abdullah. Lamas, probably I should ask the first question. You touched on albumin post large volume paracentesis, and you suggested that we should use albumin after 5 liters of removal of fluid. So what's do we have a percentage? Do we have an equation? How much do you give per liter removed?
This is working. Yeah. That's a great question. I think there's a lot of controversy in terms of when to use albumin, and there's also just as much controversy in terms of how much do I give albumin. Part of it has to do with what's available. So within our region, not every country has the 4%, and not every country has the 20% or the 25%. So part of it has to depends on what is available within the country. The 20% is what we typically use, and I think 20% is also what others are using at the time that they do paracentesis. Now, in terms of how much volume you would give, that's the tricky part. But 1 to 2 is probably grams per kg. But again, that tends to be depending on the patient's underlying condition and comorbidities. So floor patients are probably different than ICU patients. Patients with hypertension may be different than patients who have more controlled blood pressure. So I think this is the tricky part, is how much do I actually give and what do I give. And part of it depends on the availability of what's in the country.
It's a comment that I would like to make. What we have heard this morning is the same message again and again. There is no evidence for this. There is no evidence for it. But from what? Well, from large randomized controlled trials. Yeah, but as it was also mentioned, these are very heterogeneous populations. I think we need to stop doing these trials. They cost a lot of money, a lot of effort, and at the end, they do not help us. So to start with the albumin administration, of course there is no evidence in the literature. There are 2 more trials that will come out for albumin administration effects on survival in patients with sepsis. The 2 trials will be negative, but from the beginning I can tell you they will be negative. However, when I have a patient coming in with septic shock and anasarca, I don't give a crystalloid. No, there is already too much sodium in all that edema fluid. I give what the Americans call salt-poor albumin, SPA. So that will help to attract fluid from the edema into the circulation. But that's physiology. You don't need to show me a large trial on this. That's a basic physiology. We know that when we give concentrated albumin, we'll need less fluid for these patients who already have edema than if we use a crystalloid. And on the other hand, when we spoke about crystalloids, we spoke about saline versus balanced solutions. What is balanced solutions? It just means that there is something else than sodium and chloride in the bottle, okay? But the Ringer's lactate solution is hypotonic. In Europe, we call it the Hartmann solution. Hartmann was a pediatrician, so he was giving that to children with dehydration, to babies with dehydration. He needed hypotonic solutions. Of course, we should not give it to patients with brain edema. That would be a catastrophe. But it's also plasmalite. Ah, plasmalite, yeah. What is in plasmalite? I have not heard the word one time this morning. It is acetate. What does acetate do? Oh, interesting question. And gluconate. Gluconate? What does it do when you give a lot of gluconate to your patients? So balanced solutions versus saline. We heard that saline solutions has only one possible problem, hyperchloremia. That's a major problem. Bad for the kidneys, yes. Well shown since 1983. Why do you want to do further big trials to show that we should avoid hyperchloremia? In some of these trials, the mean sodium levels went to close to 110 milliequivalents per liter, which means that some patients had close to 120 milliequivalent per liter of chloride. That's malpractice. It means that people did not look at chloride levels. They just wanted to continue saline when chloride levels are increased. Why don't we individualize? Why don't we look at chloride levels? Oh, Jean-Louis, that's complicated. Complicated? Don't you look at sodium, potassium, bicarbonate? Why can't you look at chloride? And if chloride levels go up, stop giving saline. That's what we do in Brussels. Isn't it reasonable? So these are some comments, my friend. Personalized medicine.
So can I ask one question from Professor Vansa? You have discussed a lot about the AI-based solutions for care in the theater where the fluid is being given as a AI-based. How far it is justified to extrapolate the theater situation in the ICU, because in the theater, patients are not that much vasodilated. Most of the time, the fluid shifts are taking place, but they are more, sometimes if bleeding is happening, more of hypovolemic. Whereas in the ICU, in the sepsis, patients are more vasodilated, less than relative hypovolemia is there, but not as per hypovolemic. So how it is justified to extrapolate those trials to?
Oh, absolutely. That's a very good point. And I presented, I'm not an anesthesiologist myself, so I presented this as a first step. We go first to somewhat less complicated patients. Now, anesthesiologists here may stop me and say, in the operating room we have very complicated patients. I agree. But in general, the situation is a little more simple than when we have to resuscitate a patient with shock and comorbidities and already organ dysfunction. So it is a first step. You are very right. I'm not saying we should apply it right away in the ICU. My talk was on the future. And exactly as I like very much Sean presenting the data on sodium chloride administration in volunteers, showing that indeed it can alter the renal hemodynamics. I think it's a very important study, but it's a first step. You may say, okay, you observe it in volunteers, what about critically ill patients? But it's the first step, and that's how we can make progress. And I think we usually make more progress from relatively small trials, like this one, small trials, than big prospective randomized controlled trials with no difference in mortality. And actually, in the big trials on crystalloids, when there was no difference in mortality, there was no difference in chloride levels either between the two groups, or hardly. There was a difference, but there was no significant hyperchloremia in patients who received saline. The Brazilian study is a very good example. They just gave a little bit of fluids initially, and they look at mortality 28 days later. How do you want 1 or 2 liters of one type of solution versus another to influence mortality? You give a bit of albumin initially, and you think you will change the mortality? Of course not.
Please.
I did my ICU in Toronto about 20 years ago. We used to give 4 liters of IV fluid before anything. Let's give fluid. Keep dumping more fluid until you reach nowhere, and then we start to over. Now I guess we have a different dose to erase all what we there and release that.
Thank you. I think I'd just like to comment on one aspect of the subgroups of patients in these clinical trials that probably warrants just a little bit of exceptional discussion, which is patients with traumatic brain injury and/or patients who have, acute brain injuries or neurologic injuries. So the SAFE trial and the guidelines that you showed, you didn't make comments specifically related to this, but the SAFE trial clearly showed a signal for harm for patients who presented with traumatic brain injury and were allocated to 4% albumin solutions. And they actually went back and reassessed all these patients in exhaustive detail on a case-by-case basis And they found some misclassification. They found some TBI that wasn't, blah, blah, blah. Long and short of it was, though, they looked at the mechanisms by which they believed the patients actually had an increased risk for mortality, and that was because of refractory intracranial hypertension amongst patients who received albumin solutions. So I think that's an important subgroup of patients that warrants some highlight on the albumin solution. But even in the crystalloid solution now, oh, you want to comment on that? Yeah.
Shortly. They recognized later that their albumin solution is somewhat hypotonic. And they wrote it. I can send you the slide if you like. They said, okay, now we have the explanation. So of course, don't give Ringer's lactate to patients with traumatic brain injury. Don't give a solution which is hypotonic. No, please. So.
Well, and I think that's a nice segue into what basics have shown now in the pooled individual patient meta-analysis is that in patients who have traumatic brain injury, hypotonic solutions relative to saline seem to be associated with a consistent and fairly strong signal for less favorable outcomes. And I think that is one of the learnings from all this. A lot of the other populations are pretty muddied, sepsis, all muddy, but the traumatic brain injury population probably gets saline and doesn't get albumin.
Yeah, it's an important point about albumin because most of the people think that albumin is hypertonic. No, albumin is hyperoncotic, but the sodium is low in albumin, and it's hyponatremic. And you can see this very well when you provide plasma filtration, and you use albumin as replacement fluid. And you will see your sodium decrease dramatically after one run of plasmapheresis because the albumin is hyponatremic.
Well, you need to look at the concentration of your albumin. In the Australian trial, it was 4 or 5%. But if you give a 20% albumin solution, of course, that's not an issue.
Any questions from the floor? I guess for the sake of time and just to keep things moving on track, I think we have a 20-minute break. There is a break from 9:30 until 10. So we'll see you back at 10 o'clock sharp in this room. Thank you very much. Thank you.
Thank you
everyone.
very much.
Thank you.
Thank you very much.